Hello, my name is Martin Hazel from Unlocking Foresight, and I, together with Paul Munday and Sean Brummett from Atkins Global, will be moderating this second seminar from Unlocking Foresight. Welcome to you all. We have a wide range of participants today in the UK, Americas, Asia, Africa, and Europe. The webinar is being recorded and will be available for viewing on YouTube in about a week. You'll notice a speech bubble in the bottom left of your screen. If you click on this, you will open up the chat window. Please feel free to add any questions as we go along, and we'll be picking these up about halfway through and at the end, when there are plenty of time for discussion. Our guest speakers today are David Lai from SAMI Consulting and David Smith from Global Futures and Foresight. But before I hand over to them for a fuller introduction, I would like to introduce Unlocking Foresight to those of you who are joining us today for the first time. We are building a community of people who are using foresight to inform and take action in shaping their own futures and that of their organisations. This community is supported by the Foresight Hub, more of which later, and events such as these. I'd also like to thank Atkins for hosting this event. We are pleased to be working with this organisation that uses foresight at the heart of planning to enable them and their clients to anticipate the impact of megatrends and to plan and design a better future for all. I'll now hand over to David Lai.
Thank you. Thank you, Martin, and good afternoon to everybody, or good morning or good evening, or wherever you happen to be in the world at the time. Welcome to this seminar on the future of work in health. I thought first of all we would introduce ourselves. I'm David Lai. I've been a director and fellow of SAMI Consulting since 2013. Before that, I worked in health for 25 years as an official in the United Kingdom Government Department of Health, as a director of a regional health authority in the National Health Service in England, and as chief executive of a government agency, the Public Guardianship Office, which looks after the interests of people who lack mental capacity to look after themselves. So I've known health as a policymaker, as a manager, as an advocate for others, and of course, as middle age begins to encroach, I'm starting to know it as a patient as well. SAMI Consulting, foresight and scenario planning is our business. We've spent a lot of time recently looking at the future of health and health services. We've been working here in the UK with the Academy of Medical Sciences, the General Medical Council, NHS providers, and the National Institute for Health Research. And in Europe, we've worked with the European Commission Directorate of Research and Innovation on its strategic planning work on Horizon 2020, its research programme, and that includes a significant health and life sciences component. And finally, we've been working informally with a network of health professionals, managers and researchers on some of the issues we'll be covering today. And you can read our blogs on the subject on the SAMI website, and at the end of this webinar we'll provide you with the links to the SAMI website, amongst others. So I'll now hand over to David Smith to introduce himself.
Thank you, David. It's David Smith here. I'm a strategic futurist, and I've worked with David and others in SAMI for a number of years and worked with them on this project for a while. And we combine experience gained from a business environment with our strategic visioning and foresight to allow us to use the methods to help organisations better prepare for the future. I mean, many of us don't see the future as being anything other than an extension of today, but most of us intellectually believe it's very different. I've worked with both European and US corporations. I've worked with the EU and local businesses and the National Health Service, and I must admit I thoroughly enjoy public speaking. And we produce many written works on embracing change, the drivers of change, technology, and our attitudes to change. So before creating Global Futures and Foresight, which is a unique independent research firm to look at the future, I created around the Unisys internal think tank, the Global Future Forum. And it was there for 5 years that I built an understanding and a network of those that are comfortable perceiving the future as something different. And within Unisys, I ran a $2 billion strategy for their company, or at least the strategy for a $2 billion venture that they were running. And in the meantime, I value working with my colleagues at SAMI and benefit from their considerable insight into the UK health industry and the industry in general. So let me just hand that back to David.
Thanks. Don't know how we're going to manage calling each other David, but somehow we'll do it. Okay, first of all, just to introduce what we're going to look at in this seminar. We're going to look at what healthcare might look like in 25 years from now, in about 2040. And to do that, what we're going to do first of all is we're going to look at the factors that are going to drive change. And we're going to do that using the STEEP methodology. Some of you will be familiar with that, but for those of you who aren't, we're going to look at the social, the technological, the environmental, the economic, and the political factors that are going to drive change in health. When we've done that, we'll take a short break, and that'll give you time to ask questions about the drivers of change. And then after that break, we'll start to float some thoughts on how working in healthcare might have changed in the world of 2040 that we're describing, and we're going to identify 10 challenges for healthcare in the future. So if we start off with social, and the big headline figure that most people know about if we look ahead to 2040 is the phenomenon of the aging population. In 2012, the UK population of people aged over 70 was about 8 million. By 2037, it's projected to be about 13.5 million. And if you look within that group to the over 80s, then the number of over 80s will double from 3 million to 6 million. And for those of you who are dialing in from other parts of the world, it's the same everywhere in the developed world. The same story, a growing number of older people and living longer as well as in greater numbers. So on the face of it, that's good news. Life expectancy has risen steadily in developed countries, and it looks likely to go on doing so. But even if older people stay healthier for longer, they ultimately will become sick. So let's look at one disease of old age, dementia. According to the Alzheimer's Society, which is a UK charity, the number of people in the UK with dementia will rise from about 750,000 in 2012 to about 1.3 million in 2040. So that's almost double. Those people are going to need looking after. And just to repeat the point, the story is the same everywhere you look in the developed world. Now, it may be that medical science will find a miracle cure for Alzheimer's and other forms of dementia so that by 2040 nobody will have to suffer the long shuffle into twilight that so many older people are facing today. And later on we will touch on the prospects of medical advances. But as things stand today, we're looking at a steadily increasing demand for health services to treat our steadily aging population. And as things stand today, there is no miracle cure for dementia. So while we're finding ways of prolonging life, we cannot halt the decay and loss of brain function once dementia takes hold. One consequence of this is that the question of how we die is looming ever larger. In some countries, such as Switzerland and the Netherlands, and in some US states, assisted dying is now legal. In the UK, as in most of the world, it is not. Interestingly, an Ipsos Mori poll in the UK found that 70% of people said that they supported the principle of assisted dying, with only 13% opposing. And I think one thing it's reasonable to assume is that the pressure to legalise assisted dying is probably going to grow into the future. Looking at other social aspects, well, there's some good news. It's not all gloom and doom. According to Public Health England, 10% of the total disease burden is attributable to smoking. And the good news is that smoking is in a steady decline. The percentage of adults who smoke has fallen from about 27% at the turn of this century to less than 18% today. And by 2040, we could be close to becoming a post-smoking society. Another piece of good news, people are drinking less. According to the Institute of Alcohol Studies, the average weekly consumption of alcohol fell between 2005 and 2010 from 14.3 units per week to 11.5 units per week. The image of the English as inveterate boozers may by 2040 have joined the stiff-collared, bowler-hatted Englishmen as a historical myth. But in other ways, we are becoming less healthy. We're getting fatter. According to the OECD, 25% of adults in the UK are obese, compared with an OECD average of 19%. If we look at Japan and Korea, then they're much healthier than us in this regard. Only 3.7% of Japanese and 4.7% of Koreans are obese, and it would be nice to think that we would start to match them for sleekness by 2040. But the trend line is heading in the other way. We're actually heading up towards the USA, where a whopping 36% of the adult population is obese. And according to some forecasts, by 2050, 60% of men and 50% of women will be obese. And why does that matter? Well, it matters because obesity means trouble. Obesity means more heart disease, more high blood pressure, leading to strokes, cancers, diabetes, and probably deterring people from taking exercise and getting out and about. In 2004, the UK Department of Health estimated that in the next 20 years, the number of strokes would rise by 5%, cases of angina by 12%, heart attacks by 18%, hypertension, that's high blood pressure, by 28%, and the cases of type 2 diabetes by, wait for it, 54%. So we face the prospect not only of aging population with greater health needs, but across the population as a whole, people living longer, with more ill health, and often with what are called comorbidities, and that's combinations of illnesses. And those lifestyle diseases are going to become more and more prevalent. Interesting to look at the question of how far illness is down to lifestyle. Our behaviour probably affects our health more than any other single factor. According to Public Health England, 40% of premature deaths are down to behavioural patterns, and that's a greater single factor than any other. The next highest is genetic predisposition, which is about 30%, and then social circumstances about 15%. So lifestyle is hugely important, and it's going to be hugely important in determining the health profile in 2040. Looking ahead as well to mental illness, that's also projected to increase. According to the Health and Social Care Information Centre, between 2004 and 2014, the number of people in contact with mental health and learning disability services in England rose from 1.1 million to 1.8 million. And mental health is strongly linked to social factors such as unemployment, social isolation, poverty, stress, etc. And just picking up on one of those, on isolation, 29% of households have single occupants today, and that's projected to grow to 40% in 2031. So if more people are living alone, if more people are unemployed or in precarious employment, then the numbers who become mentally ill are going to rise. So those are some of the social factors that are going to drive health. I'm now going to hand back to other David Smith, who's going to talk about some of the technological factors.
Hello. All right. Thank you, David. Hopefully you can hear me.
Yes.
Sorry, I'd lost the connection for a moment. Attitudes to health and to health services are also changing, and we demand more and more as we get older, and we complain if we don't get it. The number of clinical negligence claims against the NHS rose from 6,600 in 2009-10 to nearly 11,900, so nearly 12,000 in 2013-14, so an enormous jump. And as UK Age Concern puts it, there are 17 million baby boomers marching towards retirement with a high set of demands and a clear set of expectations of what they want in retirement. This is a very different profile of what we saw before. And if you ask people for how much they want to engage in their care, then many feel they're not involved enough, they're not asked to be involved, and indeed they don't have the opportunity to get involved. So we no longer, so if you think about technical issues as we move forward, we no longer rely only on doctors and nurses. We go online, according to the Department of Health, and over 50% of people now go online to self-diagnose. And in a survey by Mintel in 2016, slightly more 16 to 24-year-olds said they trusted information from websites and apps than from health professionals. So with smaller households and fragmented families, people rely more on health services and less on the family rallying around and managing minor health and emergencies in the future, including all sorts of illnesses. So we are increasingly becoming more isolated, we're relying more on technology, and to some extent we're frustrating the medical profession. So turning to technological change, there are many exciting developments projected in the field of medicine, and we'll come on to those in a minute. But first of all, let's look at how people might use technology to change the way they manage their health and interact with health services. And in this chart you can see there's a significant number of younger people who feel that online and digital tools, and at least forums, give them the answers they feel they're looking for in terms of their health. So let's think about self-care for a moment, the degree of connectedness. So technology will empower people to manage their own health. Apps, implants and wearables linked to smartphones and watches and all manner of new technology will allow them to monitor vital signs such as blood sugar levels, pulse and blood pressure. Of course, in effect, people already do manage their own care. The average diabetic has some 3 hours of contact per year with a health professional. For the other 8,757 hours, she is on their own. But technology should allow us to do it better. If we think further about genomics and personal medicine, genomics offers the prospect of drugs tailored to people's particular genetic makeup, or targeted on very particular strains of disease such as cancers. Gene splicing offers the prospect of screening out hereditary illnesses or blocking diseases. In California, gene editing has been used in trials to delete the gene through which HIV gains entry into the body's cells. So there's some very practical uses being put to the latest technologies in the medical profession. So further in the future lies the prospect of replacement organs, and there's a view here of an organ that may have been produced either in a petri dish or in a 3D printer. Either way, whatever method is used, that we'll be able to replace organs using our own stem cells, and the use of technology to develop nanoswarms to swim through the body and its organs to sniff out and destroy potentially harmful cells is growing rapidly. So along with these technologies, big data and connectivity are increasingly the power of artificial intelligence and the web to improve healthcare and make it more accessible at any time of the day or night. In trials, artificial intelligence, machines like IBM's Watson, are outperforming humans in reading scans and diagnosis. This is hardly surprising when we can carry on in their artificial brains, when they can carry in their artificial brains every medical textbook and research paper ever published. The Department of Health has estimated that the effective delivery of telehealth can reduce the need for emergency admission to hospitals and length of time people need to stay in hospital, even mortality rates. And across Europe, the number of connected care systems is growing fast, projected to more than double between 2013 and 2019. But what if technology is slow to deliver? The Human Genome Project has made impressive progress in mapping our genetic codes, but has relatively little to show so far in terms of new treatments. Many people are resistant to the idea of Big Brother sharing their personal data. And we've seen some of that perhaps in the media today, when we've seen a National Health Trust fall foul of a data regulator in terms of passing data to Google. data is the new oil of the new digital economy, and we're going to see a great deal of debate over what sort of data is reasonable to share at any moment in time. But of course, it's the lifeblood of being able to produce better outcomes. And those 3D printed organs are still some way off. And the brain is the part of the body we least understand. And the aging population and the rise of dementia is already upon us. We should hope for the best and work towards it, but we should prepare for the worst. David, over to you.
Thank you. Turning to the environment, there are other challenges ahead. We face the possible impacts of climate change and also other environmental challenges. If we look at the environment, we face the risk of new diseases emerging. Rare diseases such as Ebola being exposed and becoming more widespread as humans advance into hitherto sparsely populated areas, or you get trans-species migration of diseases. And of course we face the risk of new strains of familiar diseases which are resistant to existing drugs. £10 million Longitude Prize was awarded to tackle the risk of antibiotic resistance. And to put antibiotics into some sort of perspective, because we take them for granted, don't we? The World Health Organization estimates that antibiotic treatments add an average of 20 years to our lives. So that's pretty important stuff. Turning specifically to climate change itself may play a hand in our health. One of the arch critics of current global climate policy, Bjorn Lomborg, has written that up to now, the overall effect of global warming has been beneficial, but he warns that by the middle of the century there's going to be a tipping point when the net effect of climate change will become negative. In the UK, the Health Protection Agency has estimated that higher temperatures will cause more illness and more deaths. Rising rainfall and sea level rise will endanger not only housing, but also parts of our health and social infrastructure. Globally, then the harmful effects of climate change could trigger conflicts and resource shortages and crop failures, and those things in turn can lead to mass migrations and upheavals of existing societies. In 2016, the World Economic Forum moved migration up to second in its ranking of global risks with the highest potential impact. And if you're watching on the screen so you can see the chart, you can see that illustrated there where migration is the long red streak which goes up from the middle of the chart right up to the top right hand corner there to show that it's moved very, very rapidly up the list of risks. Coming back home, just looking at the local environment, increasing urbanization is something that in many ways futurists believe to be potentially beneficial, but it also brings risks. Less affordable housing, increased pollution, higher population density, and that in itself may have direct effects on health. Already London's air quality and deaths attributable to air quality are significantly higher than the average for the rest of the UK. And there may be indirect effects of urbanisation as well. More noise, more of an everyday struggle just to get about, more crime, and that can lead to both an increase in physical illness but also in mental illness, remembering the earlier point about the social factors that influence mental illness. So that's the environmental picture. We'll now look at the economic future, and I'll hand back to other David to do that.
Thank you, David. This is getting slightly ridiculous, but this is David Smith. I'm very happy to talk about the economic implications of what we've been talking about. In terms of steep, we're in the second E of steep. So turning to the economy, the health of the nation depends very much on the strength of the economy. In 2013, ESPAS, the European Strategy and Policy Analysis System, was forecasting a bright future for the UK, for the economy, all the way through to 2030, with GDP steadily rising. But in a post-Brexit environment, and one with the prospect of protectionist barriers and trade wars, can we be so sure? A sluggish economy will have both direct and indirect impacts on health. And obviously we can think of a great many of those. But the chart there shows that 40 years ago, of the top 7 economies, 4 were in Europe. And the forecast by 2030, with that 2013 view, was only the UK from the European nations would remain in the top 7. So a massive change in the performance or the relative performance of nations around the world and those in Europe. So thinking about how that moves forward, think about health spending. Most obviously, a sluggish economy will mean that there is less money for health and social services. The UK spends less than 10% of its GDP on healthcare, as compared with 11% in Germany and Sweden, and 12% in France, and 17% in the United States. And you can see that on the chart in front of you. And finally, and in slightly more detail, a sluggish economy will mean that there are more people who are unemployed, precariously employed, and or living on low wages. Piketty and others have noted the shift in the distribution of wealth in developed countries, away from labour and towards capital. And it's this capital that's employing automation to make its margin. To add to this risk, we face a culture where rapid technological advance will radically change the jobs that people do, and in some sectors create mass unemployment. For example, the rise of autonomous vehicles will put truck drivers, cab drivers and delivery drivers out of work. In their oft-quoted research, Frey and Osborne of Oxford University have estimated that almost half of the UK jobs are at risk from new technologies. In fact, Carney, who's the governor of the Bank of England, has quoted that figure even recently. And even the OECD's more cautious estimate of 11% implies significant churn in the labour market. So a growing economic inequality will feed growing health inequality. The Marmot report in 2010 showed that the wealthiest people in England have a disability-free life expectancy of 72 years, whilst the poorest have a disability-free life expectancy of only 50 years. This is a massive disparity. If we want people to be healthy, we want them to be working and prosperous. So from an economic standpoint, you can see there's enormous impact on our health, depending on the nation or our region's performance. David.
Thank you. Last but not least, we come to politics, and specifically the politics of health. Well, let's start off globally. We face uncertainty about the future stability of the world we live in. Since the fall of the wall in 1989, we've been through an era of relative peace. It may not seem like it if you watch the news, but there have actually been fewer conflicts around the globe. There's been increasing prosperity in many regions, leading to dramatic falls in key indicators of health, such as malnutrition and infant mortality. Will this continue? The world seems to be a bit of a dangerous place at the moment, and that may be a direct consequence of the financial crash of 2008. America has elected a president on a protectionist America First ticket. The UK has voted to leave the EU. The EU has its own internal problems, with the widening gap between creditor and debtor countries within the Eurozone. Russia and Turkey have become more assertive, shall we say, on the borders of Europe. And the Middle East continues to be a war zone, as it has been more or less constantly since the Second World War. We obviously don't know how that's going to pan out in the future, and we'd hope that prosperity would resume and continue. But if the world becomes less stable, then it will suffer economic and environmental harms, and those in turn will impact on healthcare. If we come back to the problem I mentioned specifically about the UK, which is Brexit, the government is going to have to negotiate and agree the terms of Brexit, and this is going to have a direct and immediate impact on health services. 10% of registered doctors and 4% of registered nurses in the UK are natives of other EU countries. Will they be allowed to stay? And even if they are allowed to stay, will they want to stay in a post-Brexit Britain? A recent survey indicated that 42% of European health staff are thinking about leaving, and the number who are actually taking the plunge has grown by 25% since 2015. The four different countries of the UK, and for those of you who are listening from outside the UK, health is a devolved matter. So you have four countries with four different systems in the UK. They're going to need to address their own challenges. Major decisions are going to have to be made. In England, health and social care are funded and managed separately, whilst in Northern Ireland they've been joined together for many years. In England, there is an internal market based on a separation between the commissioners who purchase health and the various providers, the hospitals and other services that provide it. And Scotland doesn't have that. So political decisions will critically affect the way in which health services respond to the other challenges that we've outlined. So that's a sort of fairly rapid sort of canter through some of the sort of main steep factors which are going to drive change. And I said we'd pause at this point. So we'll pause here for questions. If there are any questions, then fire away and we'll answer those, and then we'll go on to draw out the 10 challenges for the future.
Yeah, we have received some questions on the chat. One from Trisha in regards to Alzheimer's. What do you think the prospects are for a cure for Alzheimer's? It would be a game changer.
Right. Gosh, yes, it certainly would. I think the thing that I find most worrying looking ahead is the aging population and the spread of Alzheimer's. Problem that we have is that at the moment we're still not sure precisely what causes Alzheimer's. We know there are different factors: malformed proteins, vascular health, inflammation in the brain, lifestyle, obesity, possibly viral factors, but we're still quite hazy on the details. And the symptoms of Alzheimer's differ from person to person, so there probably are different forms of dementia as well. There are some attempts to look at methods of prevention, looking at people's diet, getting people to exercise, getting people to engage socially and do cognitive activities to try and exercise the brain in the same way as it exercises the mind. And if you are fit and healthy and slim, then you probably are sort of reducing your risk of Alzheimer's. But there's no immediate prospect of a cure. There are drugs like Aricept. Aricept's been around since the 1990s. I think it was the first licensed drug for Alzheimer's, and it can relieve the symptoms, but it only works for a while, and then the disease continues on its path. There's obviously a lot of talk about work coming out of research into genetics and stem cells. and the possibility that that might lead to some sort of regenerative processes or indeed lead to new drugs. But I'm afraid it's a long way off. I was talking a couple of weeks ago to a professor in Cambridge who knows much more about this than I do, and we were talking about the general direction of health, and in his view the brain is the organ that we least understand, and he thinks that the big breakthroughs in understanding of the brain and being able to make major interventions in the brain will probably be in sort of 2040 to 2080. So prospects don't look brilliant at the moment.
Yeah, we have time for a second question. This time from Graham, who's asking, will the advent of replacement body parts be a disincentive for people to change their behaviours? Won't it encourage them to carry on eating the wrong things and not exercising?
Shall I answer that, seeing as that's about 3D printing? It's, I think you've hit the nail on the head. I think a little bit like ABS brakes in cars allowed us to drive closer and brake later. We'll be able to run more extreme lifestyle choices on the hope of producing fairly safe, relatively easy to install replacement organs. So yes, you're right, it will change our preference, but it won't be available to everybody in one moment, and it probably will be available to those with financial capability. So it's going to be a very interesting and divisive technology in the early stage, but yeah, I think you're right.
Okay, I mean, thank you for those questions, and we'll move on to the next bit and talk about challenges for work in health. But I mean, that leads in very nicely, because that sort of behavioural change in patients is the sort of thing that's very difficult to project, but it's the sort of thing that health services and health professionals are going to need to take into account in the future. We've identified 10 challenges for work in health, and we're going to go through each of those 10 in the second part of the webinar. We will sort of go through them at a fair pace, so we've got a bit of time for questions at the end. I'm going to hand over to other David, and he's going to outline the first 5, and then I'll do the second 5. So David, back to you.
Thank you, David. I'll try and do this relatively quickly, but they're all very interesting in their own right. The first of the 10 is sort of what is healthcare. So if the health service is simply to seek to cope with the rising tide of older people and people with comorbidities, they will sink under the weight of rising demand and rising expectations. They'll need to work with people to help them to keep themselves healthy. So there's health and there's well-being, and there's also illness to be recovered. So sometimes the key to health for individuals will fall outside the strict boundaries of health. It's about housing, employment, debt management, people's family and friends and what they do, and other social and environmental actors will be the true determinants of people's health. So health workers will need to be joined up with their local bodies and agencies. And that means health considerations will need to be addressed across the whole of social policy. Senior health managers and professionals will need to understand and advocate for the links between health and other sectors, the ones that we've just mentioned. So major development projects will need to require to conduct a health impact assessment at the beginning of the design stage. So quite a significant change, perhaps, just posed in that one question. Moving rapidly on, so let's think about different needs in our health system. In future health services will be larger populations of older people with comorbidities rather than single conditions. These people will have social as well as medical needs. They'll cherish their independence and fear being forced into institutional care. Social and other services will help to keep them going for as long as possible. If technology does not deliver effective treatment for dementia, as was mentioned in that question, then there will be massive demand for institutional and residential care. And the pressure for assisted dying in the UK may become overwhelming. The growth in mental illness will also challenge services to diagnose people, diagnose them early, and find ways to help them to stabilise their health. As with older people with comorbidities, the keys to this will be as much social and environmental as medical. And the third one we have here is about partnerships with patients. So patients will need to become partners in their own care and that of their children. Healthcare professionals will need to encourage them to take ownership. Frontline staff will need to be good communicators. They will need to understand what individual patients are and are not willing to do. Some will be motivated to manage their own health. Many more will show initial enthusiasm, which may quickly fade. Others will not be willing at all. Personalized medicine will not only be about whizzing new technology, it will be about the ability to tailor healthcare regimes to individual patients. So what about doing different things? We do not know precisely how quickly technology will impact on healthcare, but we can expect many diagnosis roles to be superseded by artificial intelligence systems. At a workshop we held in April with NHS staff, the consensus was that some roles will disappear totally, others will reduce in number. Specialisms will become narrow. There will be a new breed of super specialists. Similarly, changing health needs will influence the sort of people we need. Comorbidities will increase the demand for general physicians who can oversee the totality of treatment that patients may be receiving and ensure that treatments are compatible, avoid harmful interactions and the risk of over-medication. Indeed, 70% of children now grow up with no tooth decay or fillings. They can reasonably look forward to a lifetime of healthy teeth. They will have more need for dental technicians and orthodontic nurses to keep their teeth clean and straight, more than dental surgeons. And finally, working in different settings. A service that is focused on prevention will be a non-hospital-based service. The emphasis will be on keeping people out of hospital, helping them to keep healthy at home via direct links, apps, email, all forms of instant messaging. Technology will allow more tests and routine screening to be done at home or in primary care environments. There may be more lifestyle interventions as well, intended to keep people motivated, occupied and active. Hospital admissions will probably be shorter and much more intensive. The aim of social care will be to keep people healthy and independent, but the growing number of elderly people will mean that there is a continuing demand for residential care, but with better integrated access to health services. The speciality of geriatrics may undergo a major revival in importance, and combined social and health specialities in elder care may be required. Indeed, these are all new things perhaps we can look forward to. David.
Thank you. Smashing silos. Well, we start at the top. The current boundaries between health and social care will change because as we become more concerned with health and more concerned with prevention, then we'll become more concerned about the wider social aspects of health and the drivers of health. But we are bedeviled by silos, and we start off at government. On the slide I've said government 1918 style. The structure of government that we have at the moment was determined by the Haldane report, which was produced at the end of the First World War and set out a model for government. And it was probably the best possible model of government that you could have in 1918. But this isn't 1918, it's 2017. And we ought to be able to join up more. At the moment, health, social services, housing, work and pensions and the environment are all reporting into different ministers and different ministries, and they all have different funding streams. And that's replicated at local level. Local authorities manage social services down one silo, and they manage housing down a different silo. Health service provision is divided between those commissioners and providers, and the National Health Service is run separately from local government. And then general practitioners, pharmacists and dentists, the primary care practitioners are funded by a separate route again. Pensions and benefits are administered by the various agencies of the Government Department for Work and Pensions. And the silo mentality applies to professions as well. Professions are educated separately, and they often fall into the trap of thinking in their own silos, although great efforts are now being made to promote and encourage multidisciplinary working. We need to crack this. There are imaginative alternatives which are being developed, and my favourite at the moment is the Northern Powerhouse in Greater Manchester, which is setting out to integrate health and social services and to integrate clinical research and other sectors into a single governance structure with a shared funding stream, agreed priorities and shared data. But I'm not here to advocate a particular organisational model. The point is simply made that we will need to think beyond silos, and we need to think about whole systems if we're going to address the problems that we face in the future. And we're going to have ethical and value questions. We always do. Ethics and values loom large in health, and particularly if you're a professional, your professional ethics are very, very important. And the impact of the aging population we've already looked at. If that heightens demands for medically assisted end-of-life care, then it's the government that has the power to pass legislation, but it's the professionals, and especially the medical profession, who will have to decide whether they're prepared to consider assisted dying to be something that they regard as ethical. And if they do so decide, they will need to determine the circumstances and the safeguards, both for patients and for the individual professionals who are involved in delivering that service to those people who want it. Other ethical questions that are going to loom large, to the extent that personalised medicine develops, then health professionals will again require some sort of ethical framework for deciding who should get access and who should not get access, and under what circumstances those decisions need to be made. And similarly, looking at the economic drivers, if resources cannot keep up with demand and further rationing is required, it'll fall to a large extent to the professionals in the front line to actually make decisions about how rationing is applied and in what areas. And again, they will want to try and apply ethical principles in making those sorts of difficult decisions. And sort of related to ethics, questions about equality. At the moment, the founding principle of the National Health Service is that it is free at the point of delivery. A lot of people have argued that that may cease to be sustainable in the future, particularly either if technology and service changes fail to keep up with demand, or if the economic situation means that funding of health care becomes ever tighter. So then the question for professionals will be, well, how do they feel about working in a system in which healthcare becomes more of a commodity than a right, where access and quality of care are determined, at least in part, by the ability of the individual patient to pay? And will people have the same emotional commitment that they currently feel to the NHS? Will working in a more commodified system make working in health more of a job than a vocation? Many of the changes we've talked about this evening rest on a good deal of uncertainty. Are we going to make rapid strides in reshaping services? Is technology going to help us, or is it going to slow us down? How fast can we respond to the rising tide of demand? And a lot of those questions we can't answer, but they will become clear as we move through the years from 2017 towards 2040. Technology could be our salvation. It could allow us to provide better and more cost-effective services and see in real time how well we're doing. But to the extent that technology fails to provide us with magic bullets, or provides them later than hoped, then salvation will lie at the hands of the people who provide the services and the other agencies that can influence health. So alongside the big ticket research into technology and genomics and all those wonderful things, there is and will continue to be an important place for evidence-based applied research, research that works incrementally with people on the ground to identify better ways of doing things and communicating that evidence base to busy frontline staff so they actually take it on board and they change their clinical practice on an incremental basis as they move forward. Which brings us on to the last of my 10 challenges. And finally, and I think it's a good note on which to end. Whatever the structure, whatever the systems, whatever the silos, whatever the funding streams, then caring for people ultimately is a people business. Even if we're happy to type our symptoms into our smartphones and receive a brilliant diagnosis via IBM Watson or Google DeepMind or whatever app we choose to use, at some point, particularly when we're seriously ill, or when someone that we love and care for is seriously ill, we will want to sit down with a human being and have a very human conversation about what that means, about what our options are, about how we're feeling, about what we can do, and about what the services can do. It's those human things that we'll need to talk about. And for that, we will continue to need professionals who are compassionate, who are empathetic, and who are communicators, perhaps even more than they are now. So whatever technology brings and whatever robotics brings, then this is still going to be a profession that desperately needs that human face. So with that, I will bring down the curtain on the talking part of the seminar, but again, we'll take a couple of minutes. If there are any questions, then we'll be happy to answer them. Thank you.
Yeah, we have received some more questions. And one from Trisha asking, if technology doesn't deliver the goods, then isn't the healthcare system doomed?
It means that we will become very, very, very dependent on the extent to which we are able to prevent illness and keep people healthy and keep people active. And that is going to raise some very interesting questions about approaches, because there are two ways of doing that, and they're not necessarily mutually exclusive, but the balance between the two is going to be really interesting. A lot of effort and research at the moment is going into behavioral psychology, how to actually influence the way people behave. So, how do you actually persuade people not to eat too much of the wrong things? How do you persuade people to exercise more? How do you influence their behaviors in a positive way? It's not clear at the moment whether or not that actually is going to be effective. And if it's not effective, then you could well be looking at the other way of influencing behavior, which is through legislation and regulation. So, for example, right at the start of the presentation, I looked at the smoking rates, and one of the things that's had a major impact on smoking over the years, it's taken time, but it's working through the system, has been a lot of government propaganda about smoking, raising the cost of cigarettes, reducing the accessibility of cigarettes, banning smoking in public places, and then of course technology has come in and played a part as well with the invention of the e-cigarette, which seems to have had quite a significant impact as well. So it may be that we will need to actually regulate people's behaviour in the same way. So if you talk to public health people, then they're in favour of levying higher taxes on alcohol, higher taxes on fatty foods and on sugar and things like that. And it may be that we'll need to look at those sorts of measures, which some people would regard as nanny state. If we can't come up with the technology, we'll have to find other ways of keeping people healthy.
Graham asks, talk about the human face of medicine. How far do you agree with Susskind and others that robots will replace doctors? Won't people, especially younger people, be perfectly happy to interact with a bot?
Well, this is David Smith. Shall I have a go at that?
Yeah.
the bottom line is that it's always generational which technology we prefer and we end up feeling we need to stick with. So if you look at the last sort of 3 generations of tech, at some point we've decided we don't really want to learn anything new, and we'd rather stop it. But that's a very patchy way of looking at it. The truth is that artificial intelligence and knowledge-based systems will at one point be augmenting our own role and our intelligence. And ultimately, for the more systemic, the more routine parts of our job and work, it'll become a replacement. So artificial intelligence will replace. So it isn't almost as if the issue is whole roles disappearing. It's parts of roles being supported by tech, increasingly delivered through a human, and other parts which will ultimately look to be pretty humdrum and routine, being replaced by bits of technology. Some will look physical, and some will look like bits of software, maybe voice-driven. So actually the mix of technology and how it's delivered will change how we engage with it. And quite frankly, I think the Greys are very engaged with playing with technology online, and often it's the 30s who find technology a bit challenging because they don't have time to learn the new tools. So it's not a pure age issue, and it is a patchy uptake, and it is about cohorts being comfortable with different technologies. But as I say, the insight, the wisdom of those technologies will be delivered in different technologies in different ways. So I think it's a great question, actually. It's very unlikely to be humanoid robots strutting around doctors' surgeries. It's far more to do with what they look at on the screen when you think they're looking at your records.
Yeah. Can I just sort of add to that? I mean, I agree with what other David has said. Just one other point. I think I would be very, very happy to interact with a bot if I want to know what's causing the little inflammation that I've got on my wrist where I wear my watch. But if my wife has got a serious chronic illness, then I'm going to want to sit down and talk to a human being. And I think that's the difference. Okay. Right. Thank you very much, everybody. This is for us, it's part of a continuing debate. It started with a discussion that some of us had last year, and then it went on. I mentioned in my talk that we ran a seminar for health professionals and researchers last month. And so we'd invite you not only to comment on this seminar, but also to join in the debate as we move forward. I said I'd give you the SAMI consulting address, and it's there on the screen now. We've got a series of blogs which we've posted on the website, and we'll probably blog again after this event as well. So really do join us in taking the debate forward and helping us to refine our vision of the future and how health systems may look. I've also given my address at SAMI and David Smith's address at Global Futures and Foresight as well, in case you want to make direct contact.
Okay, our time is up. Thank you, David and David, for a very insightful and challenging seminar on the future of health, of work in health. We will be sending out invitations to our members only LinkedIn community for those of you who wish to continue the discussion on the subjects raised, and you're all welcome to register at the Foresight Hub to explore the content presently available. Copies of these slides used today will be available shortly to download from the Hub, and we will be posting a copy of this webinar on YouTube and SlideShare in the next few days. So feel free to share with your colleagues. Wish you all very well, and goodbye.